Welcome back to the Deep Dive. We're here to break down complex stuff into something, really clear and useful for you. And today, we're looking at something that genuinely feels like a medical miracle in our time. Hepatitis C, HCV. For so long, getting that diagnosis, it was just heavy. A chronic disease, often debilitating, and the treatments, difficult, to say the least. So our mission today is to unpack how that bleak picture got completely turned around, and pretty fast, actually. We're talking direct-acting antivirals, DAAs, how they've made Hep C not just manageable, but for most people, actually curable. We'll get into the universal treatment guidelines, the simpler care pathways, even approaches for specific groups. The big question, how did we get here? How can we talk about a cure now?
And that's really the core of it. It's also key to understand these aren't just dusty old recommendations. The guidelines were sort of drawn on, they're constantly being updated. Think IDSA, AASLD, the big players in liver disease and infectious diseases.
Right, so it's evolving fast.
Exactly. It shows the speed of the science. And the philosophy behind it all is pretty clear. Universal DAA treatment. The aim is curative, safe, short treatments. The big goal. / HCV prevalence and, the burden it puts on people and health systems.
Okay, let's really get into that. You used words like miracle, game-changing. Maybe give us a sense of the before. What was it like for a patient before DAAs? And then contrast that with today. What makes these DAAs so, revolutionary?
Yeah, that's a great way to put it, because the difference is it's night and day, really. Before DAAs, treatment was mostly interferon-based.
Ah, interferon. I've heard stories.
Oh, yeah. Patients faced months of injections and the side effects. They were often brutal, severe flu-like symptoms, crushing fatigue, depression, just really debilitating stuff. Plus, the treatment itself was complicated, long, and honestly, success wasn't guaranteed, not even close sometimes.
So people suffered through all that and might not even be cured.
Exactly. Many couldn't even finish the treatment because the side effects were just too much. It was a really tough path with an uncertain end. Now, jump to today. DAAs. The philosophy now is strongly recommending universal DAA treatment. Pretty much everyone with acute or chronic Hep C. The only real exceptions are folks with a very short life expectancy, where, sadly, treating HCV wouldn't change that outlook.
Okay.
But the massive leap is this. These DAA therapies, they are curative for most people. They're incredibly safe, very few side effects compared to before, and they're relatively short.
How short are we talking?
Often just 8 or 12 weeks. Compare that to months and months before.
Wow.
Yeah. And those older treatments, even some of the first generation DAAs, they're basically obsolete now because the newer ones just work so much better, higher SVR, sustained virologic response rates.
SVR, that's the mark of a cure, right?
That's the benchmark, yes. So we've gone from this painful, often failing treatment to something quick, tolerable, and incredibly effective. It's a huge shift.
It really is. Going from months of misery with maybe a 50-50 shot to a few weeks of pills with a 95% plus chance of cure, that's life-changing hope, not just medicine. So, okay, these treatments are amazing, but how do we make sure people can actually get them? Effective drugs stuck on a shelf don't help anyone.
Right. And that's exactly where a lot of the effort has gone. It's led to what we call simplified treatment algorithms. These are designed specifically to get DAAs to more people easily. We're talking treatment-naive adults, people who haven't had treatment before. That includes people co-infected with HIV and those who either don't have cirrhosis or have what's called compensated cirrhosis.
Compensated cirrhosis. That means the liver is damaged but still working okay.
Essentially, yes. It's classified as Child 2A. Their liver disease isn't severely impacting function yet. The whole point is to cut out unnecessary steps for these straightforward cases. And a really key part of this simplification is the minimal monitoring approach.
Minimal monitoring. What does that mean in practice?
It means we now have solid data showing that for many patients, you don't need all the frequent blood tests and clinic visits during treatment that we used to think were necessary. The cure rates, the SVR rates, are just as good with less monitoring.
Okay, so what does it look like then?
Well, often it means no pre-treatment genotyping, figuring out the exact strain of the virus first.
No genotyping. That's interesting.
Yeah, because the drugs are so broad now, sometimes the pharmacy can dispense the entire 8 or 12-week course right at the start. There might be no scheduled clinic visits during the treatment phase, maybe just remote contact, a phone call or telehealth check-in to see how adherence is going, and then testing for the cure, the SVR, after treatment finishes.
That sounds incredibly streamlined.
Yeah.
Dispensing it all up front, no routine labs. That really lowers the barrier for someone who has trouble getting to clinics or taking time off work.
It absolutely does. And the reason this is possible is largely down to these fantastic pangenotypic DAA regimens.
Pangenotypic meaning they work against all the different types, the genotypes of HCV.
Exactly. Pan means all. Genotypic refers to the genetic type, so these drugs hit genotypes 1 through 6. That's why you often don't need the genotyping test beforehand. Good examples are Gracupra verpibrentosvir, that's often just an 8-week course, even for people with compensated cirrhosis. We see cure rates around 98%.
8 weeks.
Yep. Or another common one is sofosbuvir velpatasvir. That's usually 12 weeks, also pangenotypic, works really well. There's maybe one small exception for genotype 3 with compensated cirrhosis. Sometimes we might do a specific resistance test called Y93H testing, just to be sure, or pick a slightly different regimen. But generally, these cover almost everyone.
So for you listening, if you have HCV, the path to cure really does sound shorter, simpler, less demanding than ever. That has to be a huge weight off people's shoulders.
Okay, but life isn't always perfect, even with simpler treatments. What happens if someone, misses doses, doesn't complete the full course? Adherence can be tough.
That's a really important practical point. And yeah, studies show it happens. Incomplete adherence isn't rare.
Yeah.
Maybe 11%, 40% of people might miss some doses.
Well, up to 40%. It varies a lot depending on the study and population. But here's the key. Missing a dose here or there, like for a day or two, probably doesn't impact the cure rate much. But longer gaps or missing doses more frequently, that can definitely lower the chances of achieving SVR. We see lower cure rates in people with poorer adherence.
So there's a threshold somewhere.
Seems like it. There are management guidelines now that help doctors figure out what to do based on, how many doses were missed, when they were missed, and also patient factors like if they have genotype 3 or cirrhosis, which can sometimes make treatment slightly trickier. We still need more research to know exactly where that critical adherence line is, but we know consistency matters.
Okay, and then what about the small group who, even with these great drugs, don't get cured the first time? Is that it for them?
No, definitely not the end of the line. There's absolutely still hope, but the retreatment strategies, they do get more complex, more specialized. So while DAAs are amazing, yes, a small percentage will need a retreatment. But the good news is we have options. Think of it like a plan B, sometimes even plan C. We might use a different combination of DAAs, maybe drugs that attack the virus's weak points differently than the first regimen.
Right.
Sometimes we might extend the treatment duration, say go for 16 or even 24 weeks instead of 8 or 12. Or we might add another drug like ribavirin, which kind of boosts the antiviral effect, especially in tougher cases. So for instance, if someone didn't respond to a regimen based on sofosbuvir, the next step might be a potent combo like sofosbuvir velpatasvir voxeloprevir for 12 weeks.
Okay, a triple combo.
Exactly. Or if they failed glycoprevir, there are other complex options, maybe even involving sofosbuvir plus ribavirin for longer periods. It gets really tailored. And there's a critical point for patients whose liver disease is more advanced, what we call decompensated cirrhosis.
Right. You mentioned that earlier. The liver isn't coping well.
Correct. For these patients, a certain class of DAAs, the NS34A protease inhibitors, are generally avoided. The struggling liver might not process them well.
So different drugs for them.
Yes, different regimens are recommended, often sofosbuvir velpatasvir, maybe with ribavirin, and usually for a longer duration, like 24 weeks, to maximize the chance of cure while being safe for the liver.
It really sounds like the medical toolkit is deep now. Even if the first try doesn't work, or if the situation is complex like with advanced liver disease, there are still sophisticated pathways to try and achieve that cure.
That's the goal. Persistence and tailored therapy.
Okay, this brings us to something really inspiring. How are these breakthroughs reaching everyone? How are treatments being adapted for different groups, maybe people who've historically had less access to care? Health equity seems key here.
Absolutely, and that's one of the most positive developments. These guidelines put a real emphasis on reaching unique and key populations. The adaptability is impressive. Think about children and adolescents. I mean, it's amazing. Kids as young as 3 years old can now be treated.
3.
Yes, with the same highly effective pangenotypic regimens we use in adults. Same safety, same efficacy. That stops the virus potentially damaging their liver over a whole lifetime.
Incredible. What about other groups?
People living with HIV-HCV co-infection. This used to be really complex because of drug interactions between HIV meds and older HCV treatments. Now, with modern HIV drugs and these new DAAs, those interactions are much less of a concern. Treatment-naive, co-infected individuals can often use the simplified DAA therapy, get cured of Hep C, with great success rates like 95% in one trial.
That simplifies things hugely for them.
It does. Then there's acute HCV infection, meaning a very recent infection. The guideline is clear. Treat it right away. Don't wait to see if it clears on its own, because often it won't. Treating early prevents it becoming chronic.
Proactive treatment. Makes sense.
What about pregnant persons? This is still evolving, but DAA treatment can be considered during pregnancy. It's a case-by-case discussion with the doctor. There aren't huge trials yet, but smaller studies haven't flagged major safety issues. It opens the door to potentially preventing transmission to the baby.
That's a really important area.
And solid organ transplant recipients. This is huge. DAAs are safe and effective if HCV comes back after a transplant. But even more impactful, we can now transplant organs from donors who had HCV into recipients who don't.
You mean using an HCV-positive organ?
Exactly. For HCV-negative recipients, this vastly increases the number of available organs, livers, kidneys, hearts. It saves lives by reducing waiting times.
How does that work? Doesn't the recipient get HCV?
They do, transiently, but then we treat them with DAAs right after the transplant, usually within a week or two for liver grafts, and cure the HCV. It's a carefully managed strategy.
That's incredibly innovative.
It is. Of course, managing drug interactions, especially with the anti-rejection meds like cyclosporine, is absolutely critical in transplant patients. And then, very importantly, people who inject drugs, or PWID. The guidelines are explicit. Active or recent drug use is not a reason to withhold treatment.
That's a major shift in thinking, isn't it?
A massive and vital one. Clinical trials show cure rates near 95% in PWID populations treated with DAAs. The focus is on cure, alongside harm reduction support, counseling about reinfection risk, and regular testing afterwards.
Treating the virus, supporting the person.
Exactly. The guidelines also cover other groups like men who have sex with men, MSM, recommending testing and counseling, and persons in correctional settings. HCV rates are often very high in jails and prisons. Treatment there is feasible, cost-effective, and crucial for public health. Linking people to care upon release is also key.
You know, when you lay it all out like that, it's clear these advancements aren't just about a pill. They're about a whole system trying to deliver a cure equitably, reaching into corners that were maybe overlooked before. It's comprehensive.
It really aims to be.
So what a journey we've taken today. We've really seen this incredible story of hepatitis C treatment unfold, how DAAs completely changed the landscape. We went from something complex, debilitating, often uncertain, to a treatment path that, for most people, leads to a cure. It's safer, shorter, and as we just heard, reaching more people than ever.
It really is a monumental achievement in public health. That shift to universal DAA treatment, the simplified approaches, minimal monitoring, and especially the tailored care for all these diverse groups, it represents millions of lives changed. A future potentially free from chronic hepatitis C is now a reality for so many, which, just a decade or two ago felt almost like science fiction.
It truly did. Which leads to a final thought for you, our listener. Considering how far we've rocketed ahead with hepatitis C, what other tough diseases might be next? What other conditions could be on the verge of a similar revolution, thanks to dedicated research, and crucially, that commitment to getting the cure to everyone? Something to think about. Thanks for joining us on this deep dive.